also thank you for providing me this opportunity to present new therapeutic avenues in AML in this prestigious forum. I don't have any disclosure. These are my objectives. We'll try to talk about diagnosis, okay, we'll try to talk about the diagnosis of acute myeloid leukemia, and we'll talk about the cytogenetics and molecular mutation with their prognostic relevance.
We can't see your presentation, and can you please open your webcam?
Can you see it now?
It's
can you see it now?
black.
Okay. You can see my presentation, huh?
No.
No, we cannot see your presentation, and even your camera is not open. So please share your slides again and open your camera.
Can you allow me to share my screen?
Yes, you're
Dr. Khan. Yes. Could you stop sharing and then share it again, please?
Not sure why it's saying unable to share the webcam. Yesterday it was fantastic. I think you have to allow me to share the screen.
Yeah, now it's working. We can see your screen now.
And you can see me also?
No.
It says unable to share the webcam. Okay, share my webcam. Is it okay?
No, we still can't see you, Dr. Mansoor.
I don't know. Yesterday it was perfect. Unable to share the webcam.
Yes,
your webcam is already in use. Please close all the applications using your webcam and try again. Can we work without the webcam?
Okay, no problem.
Yeah.
Go ahead. Thank you.
Okay. So these are my objectives. We'll talk about the diagnosis with regards to molecular mutation and cytogenetic and really a prognostic relevance for different types of AML. And we'll discuss the treatment strategies in patients less than 60 years of age and more than 60 years of age. And we'll talk about the treatment strategies in those patients who are not fit for intensive chemotherapy, consolidation therapy, and we'll also talk about the treatment strategies for relapsed refractory AML patients. And we'll discuss some of the landmark trials, especially for the target therapies used in AML. And as we know that in last 10 years, there has been significant development in AML with regards to different predictive biomarkers and especially the availability of the target therapies. And in 2010 and before, we used to say like the only medication which were developed and introduced into the AML were anti-emetics such as benicitron, ondansetron, and apipitin. But now we have a bunch of new target therapy that we have to consider in the treatment of AML now. AML is an elderly disease with a median age of 65 years. It's according to Global Cancer Observatory Report of Saudi Arabia 2018, it's the fourth most common cancer leukemia in general, and the second most common leukemia is acute myeloid leukemia. And we are estimating that there is around 300 new cases of AML are diagnosed in 2020. And the diagnosis of the AML, there is a pretty clear definition of AML from WHO. So WHO says that the bone marrow finding that you do from the bone marrow biopsy that should be consistent with AML, and there is some blast count concentration that the blast cells should be more than 20%, equivalent to 20%. And in some situations where the blast count is less than 20%, but the patient has the AML defining cytogenetics such as core binding pattern, which is translocation 821, inversion 16, translocation 1616, and translocation 1517. No matter what count of the blast we have, it is still AML. And the other thing that has changed recently is the classification of acute myeloid leukemia. It used to be classified by French American British classification. However, WHO updated their guideline in 2016, and they have replaced the French American British classification with the 5 new categories of the AML. For the diagnosis of the AML, we definitely need to do the complete blood count, but the most important things are the bone marrow biopsy, and that will diagnose the AML with regards to the histopathological finding as well as the blast count consideration. But one of the most key elements of the diagnosis is actually to do cytogenetics and bunch of molecular mutation, and for that we do next generation sequencing. And also AML is an aggressive disease and it's a fatal disease, and that's why allogeneic stem cell transplantation is one of the recommended treatment options for adverse risk disease. So we have to do HLA typing for the patient and family. That's a very important slide. It talks about the risk stratification of AML according to the cytogenetics of the gene mutations. And basically there are 3 different risk categories of the AML. The favorable risk, I mean, this slide mainly talks about the prognostic relevance of the AML, like what kind of treatment are we providing to the patients. So if there are favorable risks, they have core binding factor coupled with the NPM1 mutation or SEPA double mutation, but they should not have the FLT3 IDD mutation, and that's the favorable risk. So these kind of patients, they're gonna go for induction chemotherapy followed by consolidation chemotherapy, and they're gonna do well with the chemotherapy alone. Whereas the adverse risk AML, which is mainly secondary AML or therapy-related AML or AML-MRC myelodysplastic-related changes, where we have chromosome 5 and 7 abnormalities, or patients having MLL gene rearrangement except translocation 9 and 11, or Philadelphia chromosome or complex karyotype. These patients are adverse risk AML, and they need definitely transplant is the only treatment option in these kind of patients. And also the patients have normal cytogenetics, but they do have FLT3 IDD mutation and all these worse prognosis mutation. They turn out to be adverse risk AML, and they have to be treated with allogeneic stem cell transplantation. So this slide basically differentiates patients into favorable risk and adverse risk and intermediate in order to decide what kind of treatment that we can provide to the patient if we have the curative intention. So for favorable, it's going to be chemotherapy. For adverse risk, it's going to be chemotherapy followed by transplant. And for intermediate risk, it's still debatable the role of the transplant. But if you're a transplant center, then you might be doing the transplant, as in Ministry of National Guard Health Affairs and as well as in King Faisal. If these are the transplant centers, so if we have a patient, for example, patient with the core binding factor with the c-KIT mutation, that's intermediate risk, we do allogeneic stem cell transplantation for these kind of patients. This slide actually talks about the complexity of the genomic landscape of AML. There's a bunch of mutations which have prognostic and significance as well as the predictive biomarker. One of the most commonest mutation is the FLT3 mutation, and which is found in about 35 to 40% of patients. And the most commonest is the FLT3 IDD, which is found in about 30% patients, and TKD, FLT3 is found in about 5 to 10% of patients. NPM1 is good mutation, SEPA is good, IDH1 and IDH2 has the predictive biomarker, and all these mutations, they have the worst prognosis and they need to be transplanted. Yesterday we've been discussing in this headline symposium, the cytogenetics and the molecular mutations are very important in order to, in the newly diagnosed patient, particularly. I mean, cytogenetics you can wait because these are mainly, they have the prognostic relevance, but some of the molecular mutation, they have prognostic relevance as well as the predictive biomarker. For example, if there's a FLT3 mutation, we want to know it as soon as possible by day 8 so that we can start mitostatin, we can incorporate it to the 7+3 or induction remission regimen because that is associated with significantly better overall survival. But unfortunately, the next generation sequencing, which is most commonly done to find out all these prognostic and predictive biomarkers, are not available in the country. We send them to Germany. But hopefully we're going to have it soon. But it takes about 2 to 3 weeks time. So we are not able to start the FLT3 inhibitor in combination with the 7+3 induction remission regimen. By the time the results comes out, it's already too late. Now we move to the principles of the adult AML treatment. There are two phases. All of us are aware of it. There is induction, remission therapy, and the goal is to achieve complete remission. We'll talk about that, the definition of complete remission. And after the complete remission, we have to consolidate the patient in order to prevent and delay the relapse. And the most important predictors of the outcome in adult AML are age. Age more than 60, you can't give them intensive chemotherapy, and you need patients with a good performance status to treat with intensive chemotherapy or to do the allogeneic stem cell transplant. We talked about cytogenetics and molecular mutation, and then the duration of the complete remission. If it is less than 6 months, it's associated with poor prognosis, and if it is more than 12 months, that's a favorable outcome. These are the examples of the predictive biomarkers in AML. For FLT3, we have two FLT3 inhibitor, Mitostatin in frontline setting, a newly diagnosed patient. You can incorporate with 7+3, and gilteritinib in relapsed refractory AML. You can use it as a salvage therapy instead of salvage chemotherapy and get them into remission, and then you can take them to the transplant. Then we have IDH1 and IDH2 inhibitor, ivosidenib and inacidinib respectively. You can use them in frontline setting. You can use them in relapsed refractory setting. And then we have CD33, which is available in every hospital, but the drug is not available. I mean, all these drugs are not registered in the country. Gemcitabine has been associated with significantly better outcome, and you can incorporate with the 7+3 or induction therapy. So if you want to stratify the intensity of the remission induction therapy, the age matters according to the NCCN guidelines. Age less than 60, your goal is complete remission, so you go with the intensive chemotherapy. And age more than 60, your goal is palliation, you go with the less intensity chemotherapy. So these are the treatment strategies for age less than 60, the patients having favorable risk cytogenetic. We talked about that. So the category 1 recommended treatment option is 7+3, 7 days of cytarabine and 3 days of Intracycling. And if gemcitabine or is available, you can incorporate along with the 7+3. That's category 2A recommendation. And the patients who have FLT3 ITD mutated AML, you can incorporate mitostatin from the day 8 till day 21. Category 1 recommended treatment option. Although many hematologists in different centers, they would like to use FLAG-IDA in patients less than 60 years of age, but still the category 1 recommended treatment option for this group of patients is 7+3. There is another medication which is CPX351. It's also not available in our country. It's a dual drug liposomal encapsulation of liposomal daunorubicin and liposomal cytarabine. And that's category 2B recommended treatment option in age less than 60. However, that's category 1 recommended treatment option in age more than 60. We'll talk about that when we come there. So the remission induction therapy, the standard of care is 7+3. You can use cytarabine. We use 100 milligram per meter square, and then you can use Intracycling for 3 doses. 3 days and 3 doses, and the recommendation is to use higher dose of the daunorubicin, 60 to 90 milligram per meter square, according to ECOG 1900 trial, which compared the high dose daunorubicin versus 45 milligram per meter square. There was significant difference in overall survival. If you're in Europe, you're using 60 milligram per meter square. If you're in the United States, you're using 90. In our country, most of the centers they're using 60 milligram per meter square daunorubicin. Does the choice of the Intracycling matter, whether to choose idarubicin or daunorubicin? In my opinion, there is no significant difference, but there was a study published in JCO in 2013, which compared idarubicin versus the daunorubicin 60 to 80 milligram per meter square, and idarubicin had demonstrated superior long-term outcome with the idarubicin. However, we need further studies to confirm this, and also it has not been compared with the daunorubicin 90 milligram per meter square. In my opinion, it's institutional preference and practice. So, for example, in our center, we are using idarubicin in patients aged less than 50 years of age, and more than 50 to 60, we use like daunorubicin. This is the definition of the complete remission that I was talking about. We need the normalization of induction therapy after like 2 to 3 weeks. And most of the centers, they will do the bone marrow biopsy at 2 weeks if the counts are recovering. or they will do the bone marrow biopsy by 4th week. So there should be normal additional count, absolute neutrophil count should be more than 1,000, platelet count should be more than 100,000. Patient should be independent of the transfusion. There should be clearance of the marrow blasts, especially the R rods, and there should be absence of extramedullary disease. This is called complete remission. Sometimes it's not possible to get complete remission in some patients, patient with the difficult to treat mutation, AML in relapsed refractory setting, or even in frontline setting. So it's okay for us to have the patients achieve everything, but except the platelet count, that absolute neutrophil count is not yet up to the mark. It's called complete remission with incomplete recovery, CRI. With the newer medication IDH1, IDH2 inhibitor, the physicians and the researchers, they have started using another definition, CRH, which is complete remission with partial hematological recovery, in which there is a clearance of the marrow blast, but the platelets are partially recovered, more than 50,000, and absolute neutrophil count only more than 500. That's called CRH. So I'm going to use CR, CRI, and CRH in my landmark charts. So that was what I talked about. We give induction therapy, then we monitor after 2 to 3 weeks, and or at 4 weeks. If there's hypoplasia or await the recovery, and once they're in remission, they go for the consolidation. And if they fail the induction, then they have to go for salvage chemotherapy and then the stem cell transplant. So this study, which was published 2002, but they looked at the prognostic relevance of the FLT3 mutation in AML patients, and they found out that the patient, those who had FLT3 mutation, they had very shorter overall survival in comparison to the patient, those who had no FLT3 identity mutation, and that was same was seen with FLT3 TKD mutation. Also, there was a study published in Leukemia Research in 2010, which looked at the prognostic relevance of the FLT3 mutation in first relapse of AML patients. And they found out actually the patients, those who had FLT3 mutation, positive AML, they had very shorter overall survival in comparison to patients, those who had no FLT3 mutation. Not only this, they also found that it's very difficult to get these patients into complete remission in comparison to the patient, those who had no FLT3 mutation. So that basically tells you that FLT3 mutation negatively impact the overall survival and disease-free survival. And in the first relapse or in relapse refractory setting, it is a terrible disease, but there is a narrow opportunity of treating these relapse refractory patients, and we really need to have FLT3 inhibitors available in our country, both in frontline setting like mitostatin and second line setting gilteritinib. So this was the trial I was referring to earlier on. This was the phase 3 trial, which treated FLT3 positive AML patient, and they incorporated mitostatin from the day 8, and that's why I was talking about that we need to have earlier. This mutation result should be out by day 8, so that we can incorporate mitostatin into the 7+3. And it was a randomized phase 3 control trial, and they found out that the overall survival was significantly better with the mitostatin arm, and event-free survival was significantly better, and the median overall survival was 75 months versus 25 months placebo. That's really almost 3 times difference. So mitostatin is a FLT3 inhibitor. It's indicated for frontline therapy in combination with 7+3 daunorubicin 60 milligram per meter squared, and also you use it in consolidation therapy and post-consolidation as a maintenance therapy. And there is a dose and schedule. I think because of paucity of time, I have to go over quickly, but you can have my slides from the conference coordinator. And the drug-drug interaction is a really big concern, because we have to use antimal prophylaxis, and they are the CYP3A4 inhibitor, and it's contraindicated to use posaconazole and voriconazole. Also have major interaction that not only they can potentiate the QTc prolongation, but also to increase the bioavailability of the mitostatin. So in our practice, when we use mitostatin on a non-formulary basis, we use enidulafungin as antifungal prophylaxis. Gemtuzumab ozogamicin can be incorporated in CD33 positive AML in combination with 7+3 in one of the phase 3 alpha 070 trial. The patient, those who received gemtuzumab ozogamicin in combination with 7+3, they had significantly improved overall survival and relapse-free survival. And you can see the induction failure was lesser with the gemtuzumab ozogamicin, relapse rates were lesser with gemtuzumab ozogamicin. And gemtuzumab ozogamycin is indicated in first-line use in the newly diagnosed AML patient as combination therapy with 7+3, or you can use it as monotherapy, or you can use it in relapsed refractory setting. It's called Militar. It's not a new drug. It was available in U.S. market and everywhere, and then it was withdrawn from the market because of the veno-occlusive disease, and that's still the black box warning for gemtuzumab ozogamycin, and it was brought back to the market with a fractionation of the doses. There are different types of the doses of gemtuzumab ozogamycin. It depends like which setting that you're using. Induction, there is a different dose. Consolidation, monotherapy, and relapse refractory, there are different types of doses. Now we move to the consolidation therapy. They have achieved the complete remission. So the core binding factor, which is translocane A21, translocation 1616, and inversion 16, they are the best predictor of the response to the high dose cytarabine. So if you have core binding factor, I will use HiDAC 3 gram per meter square over 3 hours every 12 hours on day 1, 3, and 5. That's category 1 recommended treatment option. If you don't have core binding factor cytogenetics, then most of the centers, they're not using this high dose 3 gram per meter square. The recommendation is intermediate dose cytarabine, although that's not clearly listed in NCCN guideline, but that's the clear practice in most of the centers. We use 1.5 gram maximum to 2 gram per meter square. And if you want to incorporate gemtuzumab ozogamycin, that's still possible. And for other risk group like intermediate risk and high risk AML, the best consolidation therapy is the allogeneic stem cell transplantation. So as we use cytarabine most commonly as consolidation therapy, we should know its toxicities. It's known to cause cerebellar toxicity and ocular toxicity, although I had not seen any in last 14, 15 years, because we are adjusting the doses according to age and according to the renal impairment. These are the predictor of this toxicity, of the cerebellar toxicity, and you have to use steroid eye drops for conjunctivitis associated with the high dose cytarabine. I will move to the AML induction strategies for patients who have age more than 60. If they are fit, you can use 7+3, and for FLT3 ITD mutated AML, you can still use 7+3 plus mitostatin. However, if they have secondary AML, which is therapy-related AML, or AML with myelodysplastic-related changes, then the category 1 recommended treatment option is CPX351, and I'll talk about the landmark trial quickly. So this is the dual combination of liposomal daunorubicin and cytarabine, and that's category 1 recommended treatment option. It has really shown significant survival benefit. So other patients who do not have these cytogenetic abnormalities, they have other unfavorable risk cytogenetics. There is a bunch of target therapies such as Venetoclax can be used in combination with hypomethylating agents or in combination with low-dose cytarabine. You can also use low-dose cytarabine. You can use hypomethylating agents as single agent. There's a bunch of other options. So that was the trial I was talking about, CPX351, which is a combination of liposomal cytarabine and daunorubicin in 5:1 molar ratio. That was the phase 3 randomized controlled trial, and the patients were randomized to receive 7+3 versus CPX351. And have a look at this. In all age group, more than 60 to 75, the median overall survival here almost 10 months versus 7 months. Median overall survival 9 months versus 5 months. So the median overall survival in this group of patients, which has really worse prognosis, has been significantly improved by CPX351. Its toxicities are similar to the agents like individual agents, and it's indicated for age more than 60, elderly AML with secondary and therapy-related AML. Then we have other low-intensity treatment options, such as hypomethylating agent. Both decitabine and azacitidine have been shown to increase the overall survival in elderly patients or those patients who are not fit for intensive chemotherapy. But they take long time to see any benefit, if there is any, and they may take up to 6 cycles to see any kind of benefit. Then we have very interesting combination Venetoclax containing regimens. We have included Venetoclax in our Ministry of National Guard Health Affairs formulary for treating those patients who are aged more than 75 years of age and they are not fit for chemotherapy. Venetoclax is very promising agent for those group of patients. So there are 2 trials for the Venetoclax, and M14358 was the trial phase 1b dose escalation and expansion trial in which the Venetoclax was combined with hypomethylating agents, and 400 milligram dose, which maintenance dose of the Venetoclax arm, achieved complete remission and complete remission within complete recovery of about 73%, which is really remarkable in this group of patients with overall survival of 17.5 months. The second trial was M14387. It was phase 1b/2 open label trial in which it was combined with low-dose cytarabine, but the maintenance dose is higher in this protocol. It's 600 milligram. And one thing that we do, there's a quick ramp up of Venetoclax. Within 3 days, you can reach 400 milligram or 600 milligram. The quick ramp up is because of the aggressiveness of the disease. When we do the ramp up in CLL, it takes about 4 weeks because that's an indolent disease. We don't have that much time. And overall, complete remission and complete remission with complete recovery were 54% with this combination, and that's really remarkable progress with the Venetoclax. So Venetoclax is a BCL2 inhibitor. It's indicated in elderly patient in combination with either hypomethylating agents or low-dose cytarabine. And the drug-drug interaction is still an issue. And if you use posaconazole or voriconazole, because we always have to use one of them as anti-mold prophylaxis, you have to cut down the dose of the Venetoclax to 100 milligram instead of 400 milligram. So that's 75% dose reduction. And you should be aware of the maintenance doses are different when you use different combinations. Then we have the Hedgehog inhibitor, Glastigib. It was combined with low-dose cytarabine in a phase 2 trial. It was compared with the low-dose cytarabine in newly diagnosed patient based on the Bright AML 1003 study. There is a significant difference in this combination of Glastigib plus low-dose cytarabine, 9 months overall survival versus 5 months overall survival with low-dose cytarabine. And that was the landmark trial which led to the approval of Glastigib in frontline therapy for elderly patients who have aged more than 75 years and they have comorbidities, or those who have young patients but they have comorbidities and we cannot use intensive therapy. Drug-drug interaction is the same concern. All of them, they are CYP3A4 substrates, so using CYP3A4 inhibitor inducer is a big concern. In IDH, yes.
You have 2 minutes, please.
In IDH1 mutation and IDH2 mutation, we have ivositinib and inacitinib, and they have also the same drug-drug interaction issues. And then we move to the relapsed and refractory AML, and that's really a big concern. No matter what kind of cytogenetics you have, it has poor prognosis. So we have to give typically salvage therapy and do allogeneic stem cell transplantation. That's the only curative treatment option. I'll use this is NCCN guideline, the recommended treatment option for relapsed refractory AML. The best option is clinical trial. If you're in the US, there are target therapy. We discussed like 3 inhibitors. There are IDH1, IDH2 inhibitor, gemtuzumab, ozogomycin. There's Venetoclax, or salvage chemotherapy like FLAG, IDA, FLAG, MEC, etc. I'll talk about admiral trial and then I will close it. The admiral trial was the phase 3 randomized control trial in FLT3 positive AML patient, which basically randomized patients to receive either gilteritinib as a FLT3 inhibitor or salvage chemotherapy such as FLAG, IDA, MEC, hypomethylating agents. You can look at the primary endpoint was the median overall survival, which is 9.3 months in gilteritinib and 5.6 months in salvage chemotherapy. And you can look at this is what I was talking about. It's pretty difficult to get this patient to complete remission, and CR plus CRI was 34% in gilteritinib and it was 15% in salvage chemotherapy. And currently we don't have gilteritinib available in our country, and what we use is salvage chemotherapy, and it's pretty difficult to get them into the remission. And the best treatment strategy is to once they are in remission, you take them to the transplant. So the more patients in the gilteritinib arm were able to be transplanted. And the drug-drug interaction is the same issue with the gilteritinib. You can use ivositinib and inacitinib in IDH1 and IDH2 mutation respectively. And then the supportive care, we have to definitely provide the supportive care to these patients, like anti-mole prophylaxis. We use either posaconazole or voriconazole, and we provide